As medical director of St. Vincent Center of Children in Evansville, Dr. Maria del Rio Hoover oversees outpatient services for children. She co-chairs with Dr. John Ellis the Perinatal Substance Use Committee of the Indiana Quality Improvement Collaborative. That's a mouthful, isn't it? I'm telling you. Help me now to welcome our next speaker, Dr. Maria del Rio Hoover. Oh, woo! Got some fans out there.
Thank you very much. Thank you very much. Thank you, all of you, for being here. Right before I came on the stage, I was thinking, how did a little neonatologist from Evansville, Indiana, via Savannah, Georgia, ever get to speak to a group like this? And I thought about it, and the answer was simple. It's about the babies. I'm here for the babies and the mothers, and so are you. So I'm honored to be here today. Before I start and we talk about the NAS initiative in Indiana, I'd like to take you back to how it all began, because we need to look at the beginnings to look at where we are and where we want to be. You've heard the statistics, you know the data, you know we have an opioid issue in our state. But way back in 2012, our then Attorney General decided that we did have an opioid epidemic, and he brought together a task force. And it was not just his staff, but he brought health professionals and other agencies together to start addressing and deciding how they would deal with this problem in Indiana. The licensing board also started some laws to decrease the incidence of prescription of these drugs in our state. And then in 2014, the state legislature passed a law that asked ISDH to bring a group of professionals together to define NAS and find ways to increase our data. Many of us had gone through our legislators and asked them to increase services. We knew that we were already dealing with primary prevention, but we had precious little services for pregnant women, and we had no way of identifying and no data to talk about the incidence and prevalence of NAS in our state. And when we asked for funding for services, they answered back, what's your data? Your data for your hospital, your data for your region, but we had no state data. And so they asked us to go back to the drawing board and come together and start defining NAS and figure out a way to gather this data. And that's how the Neonatal Abstinence Syndrome Task Force was formed. We're under the direction of the Indiana Perinatal Quality Improvement Collaborative, and together we report to the governing body of the IPQIC. There were 5 deliverables back then, and we had about 5 months and 60 passionate members who all had a great idea, but different ways of implementing it. Our first deliverable was a standard clinical definition of NAS. I think different hospitals, different physicians were defining it in different ways. The second one was a standard uniform process for identifying NAS. How do we identify the mothers who are at risk for substance use disorder? And do we do it early enough? And are we consistent in our identification of these women? The third is an estimated time and resources needed to educate hospital personnel. How are we consistent in our education? And identification and review of appropriate data reporting options. Data was important. We had very limited data. And then they added one more deliverable, the development of a pilot process to identify appropriate and effective models. They wanted to take our recommendations and put them into play to see how they would work in a hospital setting and with the hospital and the medical staff. The task force came together. It was interesting. It was a great deal of work, but we had an incredible amount of passionate people from throughout the state. We had neonatologists, pediatricians, obstetricians, maternal fetal medicine specialists, educators, and members from all the agencies throughout, and support from all of them. So we not only had the agencies and the organizations, but we had those in the trenches, the nurses, the staff that were working with these women and babies. And so we did some research. We decided to look at the evidence. We also researched other states and what they were doing. And then we came up with the basic recommendations of a definition first, which came up as newborns who are symptomatic and have 2 or 3 consecutive Finnegan scores of equal or greater than of a total of 24, and have one or more of the following: a positive toxicology test or a maternal history of a positive verbal screen or toxicology test. I know that we will be missing some babies if we were strictly adherent to this definition, but we wanted to carve out a diagnosis of NAS on babies who are symptomatic but may not be symptomatic due to opioid exposure in utero. We also recommended a perinatal protocol, and initially our ideal perinatal protocol would be for a verbal and a urine screen on the first prenatal visit. We've got to do this to identify the women that are at risk for SUD so that we can work with the mothers and treat the mothers appropriately. This will lead to better outcomes in the mother, better outcomes in the baby, and the compliance of the mother-baby diet and the maintenance of the mother-baby diet. This was unfortunately unreasonable because in the private practice setting, it is hard to be consistent with the protocol of both. Some of the doctors in the private practice setting felt uncomfortable. There was an issue of funding. If we were going to do a urine screening on all women, whether they complied or agreed to or not, who was going to fund it. So we decided to make a recommendation of the verbal screening, which should be happening in all prenatal settings, but also the urine toxicology screening, if possible, if mother consented to it, a recommendation. And then we made the requirement for the pilots to conduct a standardized verbal screen and a toxicology screening at delivery. We would then conduct a cord tissue screen on all babies of mothers who were found to be at risk for substance use during the pregnancy. So the cord screens that we did were only of those babies who were identified by prenatally or either in labor and delivery to be at risk for SUD or to have substance use disorder. The task force then moved on to the pilot process. Data collection was an issue. The 4 hospitals that agreed to be our first pilot hospital, Schneck, Columbus Regional, Community East, and Hendricks, were doing it on their own. There was no funding to help support this, and we wanted to be respectful of all the things that we were asking these hospitals to do. So asking for them to do incredible amount of data collection at this point was unreasonable. And so we limited the data collection to the reports, the positivity reports we got from the drug testing lab, and asked the hospitals to give us some data related to the total number of births and the number of babies that were born with a diagnosis of, or had a diagnosis of NAS. So these are the only data elements that we were collecting at this time. And the implementation began in January of 2016. What are the findings of that first year of pilots? The drug of choice changes depending on location. We identified that in a certain region in the state of Indiana, there was a high incidence of use of cocaine than there was of opioids, even though overall we have an opioid epidemic. Now this data is de-identified and it goes straight to the health department, so I do not even know what region that is at this point. It is given back to us as a global data that you will see for the entire state, but we did identify, or the state did identify, that there was a specific region, and you will see it in our data that was higher with the cocaine report. There was definitely a lack of treatment programs. We talk about primary prevention. Secondary prevention is serving the women that are already diagnosed with SUD. Where are our treatment programs for pregnant women? I know that our state legislature passed some laws, and it's a beginning, but it's not enough. And we all know, as we sit here, that there are not enough programs to serve these women, and they're not comprehensive enough. It's not a bad thing. We just need to work harder at this if we're going to deal with this epidemic. There's a lack of support services. A treatment program is not enough. Medication-assisted treatment is good, but it doesn't help if there's no care coordination and communication amongst all the providers that are taking care of this mother-baby and maintaining the mother-baby diet. The screening was only done at delivery. We would like to have that screening early on. We've got to identify the mothers prenatally, if possible, during the pregnancy, or maybe even preconception. Inconsistency in the use of the Finnegan stool was something that we also identified. Dr. Finnegan developed the Finnegan scoring tool many years ago. She modified it to make it shorter and easier, and that's what we all call the modified Finnegan. What we didn't realize is that there were many versions of the modified Finnegan, and so many hospitals were using different versions with different scoring, which could affect our definition of NAS. So that was one of the findings that we had, and data collection, you're going to see throughout my talk, it was very limited. But we had successes. The obstetricians initially, and we had the trenches at the table. So we had obstetricians from rural and urban areas that said, how are we going to do this? I'm going to test mothers. I'm going to identify that they have an issue, a problem, substance use disorder, and where do I go for intervention? I have nowhere to take them. And then it becomes my responsibility, and I don't know what to do with them. It's easier not to ask the question, and then you don't have to deal with the answer and the consequences. But they realize that we've got to ask the question, we've got to identify if we're going to get the services. So what did they do? They stepped up to the plate, and we had obstetricians that were initially very hesitant. Those same physicians are now providing MAT. And we have family physicians that are providing MAT throughout the state. And we have hospital administrators and hospital systems that have put money into this program so that they can provide care coordination and support services for the women that they serve. The community mental health centers developed a pilot project that, and this was along with our Medicaid entities who are also at the table and have been supportive of this whole process, to provide MAT for women diagnosed with substance use disorder early in the pregnancy and who are on Medicaid. This is in the early infant stages, and not all community mental health centers are participating, so more to come on that. And we were able to pass a law, and if there are any state legislators here, pass a law to protect the woman who is pregnant from prosecution based solely on a positive urine screen. We had a major concern throughout this course that this is not a punitive, this is a medical, it's a chronic medical issue. And many of the members of our committee were afraid that anything we did would just create fear or prevent women from seeking pregnancy care early in the pregnancy, and already our rates are low. We didn't want our initiative to make those rates lower. So we're very protective to make sure that the mothers understood and the women of the state understood that our initiative was protective and with them, not against them. And also, there was better coordination and communication amongst the care providers. I think the buzz started. The OBs and the neonatologists and the pediatricians, we talked to each other, but not often. Now we were talking, we were communicating. We started to realize that we had a common bond. Because of all this, the Indiana Neonatal Abstinence Syndrome Task Force then became the Perinatal Substance Use Committee. And you've heard that this is not just about opioids, that it is about substances. Substances used that are taken by pregnant women can affect the baby in many ways, and it's not just about opioids. As we look forward to the next few years, the tasks have changed a little. We are going to oversee and support the pilot process as this has increased, and 23 additional hospitals stepped up early in 2017 to participate. Not all of them have joined us, the majority have. So we have a large number of rural and urban hospitals that are participating, and 4 state hospital systems. IU, St. Vincent Community, and St. Francis are all systems, hospital systems that are participating in our pilot process right now. The use of a single laboratory for cord testing was important. At one point, we didn't require this, but we have identified that some labs have different cutoffs than others, and this could skew the data. So we thought it was for more consistency and better clarification of the data to use a single laboratory for our cords. And we expanded the cord tissue testing, which included 13 substances initially, to include alcohol. I think fetal alcohol is an important, or alcohol exposure during pregnancy is very important. I think we're missing the diagnosis. We're seeing a huge number of children with behavior and emotional problems that we can't identify the root cause of that problem. And it could be due to alcohol, and we're just not identifying it early so that we can implement services for these children early. And we changed the nonverbal the scoring tool to include domestic violence and depression. You've heard about the 4 Ps and the 4 Ps plus. The 5 Ps is similar to the 4 Ps plus, except it's free. The 4 Ps plus is copyrighted. The 5 Ps is available. It's validated, and it includes domestic violence and depression, and that's the one that we recommended. And we went back to only one neonatal screening tool for consistency and standardization, the Rio Finnegan Neonatal Abstinence Syndrome tool. I don't think I have a pointer to point to all, but I will take you through these slides, I think from your right to left. And you will see that the red, this is a sample from January to September. Only our pilot hospitals, which represent approximately a little over 9,000 births, which is about 10% of the total births in the state of Indiana. So this is a limited sample, but it's the data that we have right now. And when you look at our positivity report, the blue is Indiana, and the red is the results from the lab from the national sample, and they sample, they have samples from throughout the United States. And you will see that in amphetamines, Indiana is lower than the national sample results, and cocaine were higher than the national sample. And again, this is directed to one area of the state, but we're a little higher. I thought that we would not see any cocaine use anymore, but it is still there. Opiates, you're going to see opioids, it's very high. Marijuana is lower than the national average. And then I'm going to take you through all those to the last two on your right, and that is buprenorphine, and we're much lower than the national data, and that just leads us to believe that we're not getting these women into treatment and into medication-assisted treatment in a timely manner. And the other one is alcohol. It is higher than the national average. This is fairly new, and I think it's a little difficult at this point to discern what this means. More to come as we try to find some root causes and get a little more data. Oh. When we look at the positivity reports, I like to look at prevalence, so I'm going to take you down this list. There were a total of 9,000, a little over 9,000 births. Out of those 9,000 births, 16% were women who were identified as being at risk or having substance use disorder. And so 1 out of every 6 women who gave birth in our pilot hospitals was identified as at risk, so the cords were tested. Out of all the cords that were tested, 40% were positive. So 40% of the cords that we defined at risk were positive. Bringing it down, out of the positive cords, 48% were positive for opioids. So almost half of all the cords that were positive, opioids were present. And out of the cords that were positive for opioids, 1 out of 4 those babies had a diagnosis of NAS. Again, our diagnosis and the definition that we had is very stringent. When you talk to other states, they're not using the Finnegan for a diagnosis. They're using if the baby is symptomatic and there's a positive urine or verbal screen or a positive cord on the baby, that is a diagnosis of NAS. We might need to relook at this. If we use that diagnosis, I'm sure that definition, that the NAS diagnosis would be a lot higher. So that you need to take a look at that in that respect. When we look at the incidence, our rate of positive cords per birth is 65.7. Our rate of cords positive for opiates was 21.6 per 1,000 births. This is some data that I've seen from other states. And in other states, positive cords or babies with positive results after birth or exposure to substances or for opiates in other states has been as low as 5 and as high as 30. This is limited to 10% of our births, but it's still a fairly high rate. And the rate of NAS is consistent with the lower rate that I showed you before. This slide is busy, but I just want you, it takes our positivity result by different levels of hospitals, but I just want you to direct to the polysubstance use, because if you look at the lower right-hand box, you'll see that 77% of our cords that were tested were positive for only one substance. We thought that we would have more positivity and polysubstance use, and this was not what we found so far. 77% of the courts were positive for only one substance. Remember, we're testing for 13. I remember in our own NICU that when we were doing the courts at 5, I think, someone said, well, you don't have a high incidence of methadone in your community. Well, we weren't testing for it. It was a separate test. So we are really testing for a great deal of different substances to make sure we capture any and all substance that the babies could be exposed to. And only 17% of those were exposed to 2. What are the challenges for our pilot process? Timely identification of at-risk mothers and newborns. The ideal and the goal is to identify these women before they become pregnant, but hopefully at the time that they identify that they're pregnant and seek prenatal care. We've got to identify them at this time, and we've got to have services to offer to them right at that time. There is no standard treatment and approach. Some of them are sent to MAT, some get case management, some are sent to therapy, some do not get anything at all. And so unfortunately, I cannot stand here and tell you that every single woman who is identified as having substance use disorder right now is getting appropriate treatment and case management. Is it our goal? Yes, this is why we're here. It's not a bad thing. It's just one of the things that we are going to aspire to. Inconsistencies in the definition of NAS. Even though we gave a very basic definition, there was still a little bit of tweaking amongst the hospitals and amongst the providers. So we need to clarify that and make that simpler. And again, limited data. That's a major issue. What are other states doing? I looked at what other states are doing, not to compare, but to assess where we were and where we needed to go. And found that Ohio, Tennessee, Kentucky, Florida, and Georgia have all designated NAS a reportable condition. Washington State has a parent-child assistant program that is a fabulous home visitation program. It carries through the first 3 years of life. It's case management for these families. So they get these mothers and the babies to the services they need. They also do a home assessment. We know that women with substance use disorder have many other comorbidities and might have an erratic home life because of their own personal issues. And so we need to help and support these women, and also not to go back to not necessarily a family, but a living family environment that is with other people that are using and abusing substances. Vermont regionalized an integrated system for opioid dependence treatment, and what they did is they integrated MAT in the primary care setting, and they felt that this made the women more comfortable with getting their MAT and also more compliant with their treatment. West Virginia and Colorado, and of course Indiana, have established legislation to protect women from criminal prosecution just because they have a positive urine drug test during the pregnancy. What about the next steps? Many things we can do, many programs we can recommend, but the committee felt that before we moved on to programs and recommendations, we needed to go back to basics and become more standard in our process. We started with the definition and identification, but we realized that there was no standard process in the care of these babies or in the planning for the care of these women. And before we move forward, we need to be consistent in this care. Lots of evidence to know that standardization in our process leads to shorter length of stay for the babies and better outcomes, and the achievement of the mother-baby dyad. So we formed 5 committees, and the committee, our perinatal substance use committee tends to, when we form subcommittees, we invite people from outside who may be experts in that specific area to help the subcommittees address these issues. And they are currently just starting to meet. A non-pharmacologic protocol, the way these babies are handled if they're identified immediately after birth, the way they are handled throughout the course of in the hospital or in the NICU will make a huge difference. But it's not just consistency in handling, it's not just making the light low, but making sure that we understand what the baby likes. Does he like to be touched lightly before we even change the diaper? How do you approach the child? And we also need to teach the parents and involve them in understanding this care, because the symptoms of NAS extend beyond the neonatal period. These babies can be symptomatic up to 6 months of age. Pharmacologic protocol is another issue. We have physicians that use PRN doses when they determine the child needs pharmacologic care, and others that use teeny doses that increase very slowly and decrease very slowly and prolongs the length of stay, and is it really creating better outcomes? And so we need to find an evidence-based pharmacologic protocol that we can all live with and use that will be better for the baby without and obtaining better outcomes without increasing that length of stay and keeping that mother and that baby together. Ideally, hopefully they won't need any meds, but many times they do. Discharge planning and medical home protocol for baby and mom are crucial. We talked about collaboration, but it's not just about collaboration. I've worked with many agencies that say we collaborate. We collaborate because we take care of the same patient, but we never talk to each other. So we need to collaborate, but we need to communicate. And that's DCS. I know you're here. You know, sometimes I try to talk to you, and there's a barrier there that doesn't allow you to tell me what I need to know, or a barrier that doesn't allow me to tell you what I think you need to know. We need to find a way that we can communicate freely, and that includes the EMR, the medical records. There's barriers to those that are providing treatment for these women. The pediatrician needs to know what's going on with the woman that's receiving MAT and services, and they need to know immediately if that woman has stopped coming to treatment or fallen off. We've got to know so that we can intervene quickly. We've got to have a home visit to evaluate the home situation and provide a safe home for mother and baby. And we don't have enough home visitation programs. So that's another thing that we need to address. How do we keep these families safe? Because we want to keep the family together. And the other subcommittee that we have is a transfer protocol. It came to our attention that certain level 1 and level 2 hospitals are currently keeping babies with NAS and even providing pharmacologic therapy, but there are inconsistencies from hospital to hospital. And these hospitals should keep the mother-baby diet together, but need to know the support and the education of the staff. They need to have a consistency in the education and support systems to provide adequate and safe care for these babies. And there's a committee that's going to make those recommendations. We are also developing a toolkit for hospitals participating in the pilot process. As more hospitals participate, and we make more requirements of these hospitals, we need to identify and sort of make a timeline of what we expect for the hospital so they have a clear understanding of the recommendations, the requirements, the policies and processes that we're recommending. Otherwise, we won't be standard in our pilot hospitals. Increased data collection is important, and we hope to achieve more data so that next year when this data is presented to you, you will have more data and more expansion of that data. Universal screening will also be important. We're only testing, we're only screening right now 10% of the total population, and of that 10%, only 16% are being screened. The problem is much bigger than this. We need to have some form of identification and screening to get a better idea of what's happening throughout our state. And expansion of support services through collaboration at the state and local level. I think as we all work together, we realize that what a region specifically may need and services a specific area of Indiana needs may not be the same in another region. So even though there will be some basic standards that we all will have to abide by, as we look at implementation of services, they may differ from area to area, and we need to start working with these agencies to see how we can develop and expand these services. I now would like to take a minute and ask a favor of all of you. I would like to ask anyone that has been involved in the Neonatal Abstinence Syndrome Task Force from its beginning to the end at any time and in any way, who has attended a meeting of the NAS or the Perinatal Substance Use Committee, who has participated in a subcommittee that we have, who has been a part of the IPQIC Governing Council or all of the subcommittees that report to the Governing Council, including our levels of care. We have a quality committee under IPQIC, and we have an education committee, and they've all been incredibly supportive to our committee. And also anyone here representing the pilot hospitals and all of the agencies that have participated, the Hospital Association, AAP, ACOG, Family Practice, and the individual physicians, nurses, nurse practitioners, and other health professionals and mental health professionals that have participated, along with the Indiana State Department of Health staff and all the staff that have helped, including Emerald Consulting, without whose help Maureen Greer and Jan Bledsoe it would not be possible for our committee to have done all the work. I'd like for y'all to stand, please, because you need to see. I'm going to tell you that even though this is a big group, and our group is not that big, and I can't see out there, but I don't see anybody standing. Yes? Has anybody stood? Maureen, I see you. Please. Ladies and gentlemen, along with this group and hiding behind the screen are Dr. Walthall, who has been extremely supportive and will come and speak to you, and Dr. Box, who has been a member of our committee for many, many years. But there's one person missing, and one person that has been very supportive. Oh, nope. That was, what, before my babies. Our Surgeon General. Dr. Adams was extremely supportive when he was here as health commissioner. He not only supported but attended the meetings and was extremely instrumental in the success of this committee and what we've done. So I think I'd like to finish by telling you that our committee's work in the past several years has been, and I hope will be, truly a labor of love. Thank you.